BT is working with First Data Bank, why you're using the multiplex drug data file.
Okay, BT is the local service provider for London and Southern England, and we are developing with CSE, our software supplier, a electronic patient record for community called RIO, and as part of that solution there are various modules, and one of those is prescribing, and we've been working with CSE and First Data Bank for about 2 years now to develop that prescribing module. Is that?
No, sounds great.
Right, that's your first edit. The prescriber module will be delivered over a period of about 4 years. We're currently at version 5, and we have deployed to one trust in London on a pilot basis, and that has been a great success.
And which hospital was that?
That was Camden and Islington Foundation Trust.
And that's a mental health?
It is. It was a small-scale pilot in mental health outpatients only. We've had further interest from a couple of other London trusts and in the south, and we will be speaking to them in the coming months with respect to further rollout. Now, we've got a couple of other releases that are fairly imminent, Release 1 and Release 1.1, and the prescribing roadmap will grow in line with those releases right until Release 2, which is due to go live at the end of 2012.
So what kind of functionality exists at the moment within the e-prescribing module? Is that the drug interactions or drug doubling, that kind of thing?
Yes, we've got. One of the benefits of developing, and we, as I said, we work closely with CSE, who actually write the software. My role is to ensure that the requirements are being met. Now, prescribing is vast, and the roadmap is fairly extensive. In version 5, we have a lot of the core functionalities, such as the active check-in and the medication search, prescribe, administration, and so on. But there are limitations at the moment with regards to the multilex drug data file, in that prescribing is at product level. Now, in Release 1, we will have a new API, .NET Toolkit, and that will facilitate the prescribing by ingredient.
Based on the feedback that you've had to date from Camden and Islington, have they been able, although it was a small-scale pilot, have they been able to provide you evidence of any benefits that they've found?
Benefits are attributable so far are to do with enhanced legibility and the process of facilitating that decision making of what particular drugs to prescribe through the active check-in. Of course, the prescribing module doesn't take away the decisions that are still expected of the clinician, but just that whole process is facilitated, and there is evidence that both pilot and beyond, through their nationally prescribing work, that clinicians do take into account those decisions and may decide not to prescribe or to prescribe alternative products.
Do you have a view at all on the frequency of the data cuts of the information that you get through for the multiplex drug data file? I understand they come out monthly, and perhaps want to talk a bit about the quality of the data sets that you get in terms of confidence that it is the most up-to-date medication information available.
Absolutely. I mean, that is one of our significant concerns, and one of the benefits of working with First Data Bank, in that the information and the updates are fully quality assured. Now, we receive a monthly update, and together with that update we get a bulletin which informs us of all of the updates, for instance, discontinued medication or changes to medications. And those are baselined within, as soon as they arrive, and we get a notification of their arrival. And then service management take that update and apply it to the RIO server, and then the trusts get a notification. The trusts that have prescribed one will get that notification, including the bulletin informing them of the updates. and it's a very smooth process. We've written a document to support that process, and we haven't had any issues to date. We also get interim updates if there are any significant clinical risks, perhaps. That's not a good thing to put. We'll edit that one out. Might not sound good. We also get interim update. Can't say it now. Sorry. Just while you're editing it.
That one.
Yes. We also receive interim updates. For instance, if a trust reports a particular issue with the data, then we can in turn take that away to First Data Bank, who will assess how that's occurred, whether it is an issue. We have had a couple of those in the work prior to go live, and they were addressed without any particular fix. If any fix is required, we will work with First Data Bank to get a speedy resolution to that. That may be prior to the next monthly update or as part of the monthly update.
Services and service review that was about to take place.
Yeah.
Is that right?
Yeah. So I've just spelled a bit of water on that as well.
There was any more you wanted to say on customer services or the ease of doing business with First Data Bank?
Yeah, if I liaise with, if I need any specific technical support, I will liaise with the software supplier, but also I have the opportunity and have liaised with First Data Bank, which has led to a quick resolution of my any issue that I've had.
One other thing that I was going to ask about, which has now completely left my brain, was any future plans. You intimated a little bit earlier about the next phases of rollout for Rio in terms of the updates that are coming. What kind of ballpark time frame are we looking at for the forthcoming updates and the extra functionality of multiplex drug data file?
Okay, so release 1 will go live this year. For trusts that, for instance, the pilot trust that is already on Prescribing, they will upgrade to release 1, and some organisations will just go with release 1. The .NET toolkit, which has been tested by CSE, is complete now, and we are all ready to instigate those changes.
Are you still looking at adopting the dose range checking functionality within the systems?
Yeah, there's some significant enhancements to the Rio Prescriber module in Release 1, and one of those is the dose range checking, and also the SNOMED clinical terms that will be used in allergies and conditions checking. So we have a conditions screen within the solution, which will allow users to record a condition, which will then be incorporated into contraindication checking for client-held conditions and for allergies also. Currently, we don't have that in version 5. Take that bit out of that bit. Currently, we don't need to say what we don't have.
Getting the benefits.
So by the time we've delivered the roadmap, we expect about 65 community and mental health trusts to be utilising Prescribing to some extent, whether it be to record a medication's history or full prescribing and administration, and that will benefit thousands of users and patients. There, got that in, didn't we? Is that all right? Might be best.
Yeah.
Okay, so let's go with that one.
Do you describe to me as a layman what the process is, what this active checking actually is within the Rio system?
So a user would search for a medication, and upon selecting that medication, they would receive clinical active checking support. This is provided on a separate screen, and it would distinguish between, for instance, client-specific conditions, contraindications, or would just give a more general overview of interaction sensitivity checking.
To know that the data that you're putting
So First Data Bank have a number of clinicians who work full time on developing the reference data, and as part of our contract with First Data Bank, we expect full quality assurance of that data, which we get. We're quite a small clinical team here at BT, and upon receiving the data, our role is to baseline that, apply that to the server, and then that would be released to trust. To quality, I know, I'm taking myself in a hole here because it's almost, I don't want to come across that we're not.
Don't make it sound like you haven't got
that we, you know, we don't care about. We just want to plug it in and get going.
What else do you feel that you haven't said that you would like to say about?
So a significant part of my role is to ensure that the requirements are met. We take the requirements, and obviously CSE are built into those requirements, and we have a number of workshops with users where we elaborate upon those requirements, and that forms the roadmap over the next few years. As part of that work, we take the certain aspects and try to develop for a better user experience. So, for instance, medication search in version 5, it's a simple search on a medication name or part name, and in release 1, there are advanced search options which will allow you to search, for instance, on route or ingredient, and that all promotes a more easy user experience. Did better during our chat before this.
When you were,
we talk away.
would you describe it then much more as like a partnership, like a team-based approach rather than the traditional supplier, customer-supplier relationship that you feel like you're working with First Data Bank as an important member of the team to achieve the end users' needs and meet those most appropriately?
Yeah, very much. We work closely, particularly with CSE, at the development design workshops, and we bring FDBE in as required, not to the workshop, but we take the output that is then analysed, and any gaps or queries which arise from that we take back to First Data Bank for their technical support and guidance in how to fulfil those requirements.
And that's very much a flexible two-way relationship that you feel that you can get on the phone and say.
Absolutely. I mean, today it's been very responsive, and it has closed down a good few issues, and it's given me confidence for the future in the remaining work that we have to do to deliver a e-prescribing solution for London and the South.
File is an important component of improving patient safety and patient outcomes across the South East.
Absolutely. One of the biggest benefits of the multi-lex drug data file is how it works seamlessly in the Rio product, and it's almost impossible to distinguish unless you've been involved in the design work. From a user perspective, they would not know whether multi-lex drug data file, how it was incorporated. It is just fluid throughout the whole system.
And it aids your patient safety.
Yes. Okay, which best one would it?
Well, e-prescribing is an important tool to aid patient safety.
Absolutely. I'm just thinking where to slot it in. Should I slot it in when I talk about active checking or talk about?
It might flow out from the active checking more sensibly. It's not to take away, the phrase you had earlier, it doesn't take away from the clinician making the decision, but it provides the guidance to ensure the best patient outcomes and improve patient safety.
Yeah, absolutely. One of the biggest benefits, I've said the biggest benefits, so we'll move away from that if you're going to use that last bit. A significant benefit of the multi-lex drug data file is its support for patient safety, which is paramount to BT, and the prescribing module, clinical safety, is the biggest driver in developing the module with users and with our software supplier. And to date, we believe that we have a sound solution to implement and deliver many benefits to patients and users alike.
I understand at the close of the first phase of the pilot session, pilot rollout at Camden and Islington, that a lessons learned session was undertaken. What were the findings of that were reported?
Enhanced legibility of prescriptions, the active check-in, the ability to assist and influence those decisions taken by prescriber. It was just a small-scale pilot within mental health outpatients, so the benefits will grow over time. We've got an inpatient implementation, which we expect from release 1, and those benefits will grow as the roadmap progresses. Goes back to my response to the updates that we receive. So we receive a multi-legs drug data file update on a monthly basis. BT simply take that update from the customer zone. We baseline that update, we apply it to the Rio server, and then there's some regression testing, installation testing that takes place. But with respect to the data, that is fully quality assured by First Data Bank, and that provides us with enormous confidence and the cost benefit that goes with that. As we would, if we were to undertake that, we would then have to employ that resource and all the costs that go with that.
Because people with mental health issues also have the full range of other ailments that affect the normal population.
Yeah, and the electronic patient record, the Rio solution is an end-to-end electronic record. There are various modules which are in the Rio roadmap, prescribing being one of them. So prescribing is accessed from the clinical summary screen, as it were, and users can be given full access or a limited level of access, or no access, and they can jump between the prescribing module back into the clinical record to view, for instance, assessment forms, progress notes, but the solution works as a whole and supports the user fully in their work to the benefit of the patient. Okay, so as part of the future development within the product, we've got changes to the way we represent the data. CSC have developed, for instance, multiple views. So we have a view for a person that would be typically administering medication, person prescribing medication, somebody that just wants to view the covered medication, and the information that is displayed to the user will be dependent upon their role. And we also have the not being restricted to a product, which is a significant enabler to secondary care prescribing. And this is one of the most significant benefits which users have raised to us of future development. I keep wanting to say release 1. So one of the significant benefits which users have been calling for is the move away from being restricted to prescribing by product, which is typical of primary care prescribing. And I think that we will see a much more significant uptake amongst, for instance, mental health inpatient units and community bed units with prescribing once that change occurs. So that's something that we're looking forward to.
So that's not generic, non-generic, or other branded. People trusts can actually select their own formulary to go in there, or
formularies and prescribing formulary.
As in the drug lists that they can prescribe if they wish.
Yeah, so they're not being typically in secondary care. It's ward health stock dictates what is prescribed, and the restriction to product-based prescribing impacts that, and that's something maybe prescriber is not available for administration on the unit. So the shift away from that, being able to choose the formulation at the point of administration administration facilitates inpatient prescribing, and the move towards that will see a significant increase in the number of users who are using the prescribing module. Stop it.